Hello everyone, welcome to the second season of the Digital Health Seminar Series, and we're starting off with Elaine. I imagine most of you know Elaine, but if you don't already, I will introduce her in a moment, just after some brief housekeeping. So this should be a tablet going around. I can see at least one by the way. So if you're in person, please register your attendance in the tablets. The seminar will be recorded and it will be published on the YouTube site afterwards. So if you don't want to be in the recording, then please let us know when we can sort something out. If you're online, please stay muted during the presentation, and there'll be time for Q&A at the end of the talk. And when that time comes, please use the Q&A functionality or just put your hand up in the chat and we can unmute you. So, without further ado, let's introduce Elaine, who is a design researcher. I mean, you can also go through it yourself, but she's a design researcher focused on grounding design work in literature, social theory, and community-based participatory design, particularly around supporting social interdependence between users. And she is a research associate with TORUS, who I assume some of you are familiar with, and also part of the big lab as well. And she also did a PhD at Bristol and a master's in Tokyo. Yeah. So without further ado, I'd like to introduce.
Okay. Yeah. Sorry. Oh, do you want to minimize that?
Actually, I don't want to touch it because it might.
They're still there, right? I didn't. Yeah. I'm like, I swear it does minimize. So because this is recording, this is all published material, so you can look it up. Probably prove that things I say are wrong. I don't know. Anyways, the talk that I'm going to give today is about adopting and adapting commercial or consumer technologies to support social care. This was work that I did as an intern, sort of, what was I? Associate researcher. Sorry, for people online. I'm looking at Aisling, who is in the audience. She was my supervisor during this. So it was two projects that we did over 2 summers, essentially, and it was worked on with Bristol City Council. So that will come up later. But these do not work. Aha, nope, wrong way. Aha, that's an awful noise. But like, to give an overview of this talk, so I know that some people, like, you've seen my face, you know who I am, but maybe you don't necessarily know what I do as a researcher or who I am as a researcher. I did hear some oohs when it was like, oh, you did your master's in Tokyo, which I feel like most people know that if they know me. So then that kind of leads to like the focus areas of what I do in my work, and then really the meat and potatoes of this talk, which is thinking about how we can work with policymakers when we do our research and actually expand our work and our impact beyond academia. This was, haha. So I am a human-computer interactions researcher, but I am mostly an artist and designer in background. So a lot of my work and background is very arts-based. So like, if you go on my website, you'll see weird pictures of like monkey masks and like I made some books and graphic design stuff. So that really does feed into how I do my work. So I do a lot of research through design work. And as a human-computer interaction researcher, I really think about how do humans use computers and how do we involve them and get them involved through creative processes in thinking about technology. I will eventually learn this. But even though I have an arts background, I really am interested in social theory and specifically interdependence theory. Now, interdependence theory is a way of accounting for interactions and relationships, and it's really thinking about how are things interconnected and how do they sort of work and ebb and flow together. So I kind of think of it as, you know, I have this beautiful image of Cat's Cradle, and it's very similar to that. So things are all interconnected, technology is involved, humans are involved, the environment's involved, and you can design technologies similar to like how you would move the string. And if you make something where you move it or tweak it in a way that it can create a new picture, so it can create something positive, or you can tweak it in a way where you end up with a tangled net. So I think that I really like that example as a metaphor of interdependency and thinking about interdependency, because of there is it does impact, I think, a lot of things. So if you're just focusing on one sort of individual aspect of technology or technology design, then you're not necessarily seeing the larger picture and not necessarily thinking about how it will impact other things down the line. So what does this mean for when I do research? So I end up focusing, sort of thinking about social interdependencies and systemic interdependencies. So when it comes to social interdependencies and thinking about technology, this is really exploring interpersonal relationships within communities and care ecosystems. So if we're thinking about health, it's really the care ecosystem that we're thinking about. And this really thinks about power dynamics. So who has a position of power, who doesn't? How does that interact with each other? How does technology impact that? And what is technology's role in creating a balance between these sort of dynamics? And then when thinking about systems, I forgot to point out with this. So you can see design work in my research. When it comes to systems, it's really thinking about exploring interconnected complex systems. So specifically thinking about the work. Someone has joined the call. Thinking about AI systems, which are really complex, where you're thinking about different models interacting with each other and being built up into sort of, in TORUS, in the case of TORUS, it's building up multiple models to build up a system that can monitor Parkinson's progression. So when thinking about that, it's thinking about what are humans' roles in adding value. And I realize that now that these are where I've so far gone with my work, but I think there's also a third sort of wave or area of interest that I have where it's thinking about not just sort of the human interdependencies or the system interdependencies, but thinking about human to system interdependencies. So this is really thinking about what we call in HCI the fourth wave, which is thinking about entanglements, where it's sort of humans and AI systems or agents, thinking of them as more equals that can kind of work together or be more interdependent. Now on to this talk, and this is thinking more so, like I said, we're thinking about interdependencies. It's building on, sorry. It's thinking about interdependencies between academia and policy. So this is thinking about how academia can work with policy and influence policy, but then also how policy influences academia. I think we can easily see that when we think of funding bodies, where it's very much like, there's a lot of like, oh, we'll do this because it's funded, or we will, fund this because, academia is interested in it. So this work that I did with Ashling over 2 summers was work that was done with Bristol City Council, and it was because Bristol City Council was very aware that in 2025, this year, we were having our digital switchover, which was basically saying that there was going to be an elimination of all analog systems and everything is now kind of broadband. I think it's pretty much all done. I think when I last looked this up, which is why there's this beautiful thing that I stole from their website in June, I think they were still, Scotland was the last of the areas to get the broadband. But because of the switchover, the council was really interested in thinking, well, we know now that the current systems that we use for social care, I think this is the slide. Yeah, the current systems that we use for social care that are analog based are now going to be obsolete and we won't be able to use them. But there's a lot of new other technologies that we can sort of apply or use in social care settings that we haven't been able to before. So this then led to us looking at Alexa for social care, and then sort of looking at sort of this passive monitoring system that was made up of a bunch of different sort of consumer technologies to like mash them together to make a system. So what happened though in thinking about and looking at both these projects, we ended up seeing sort of positives that could come out of applying sort of these consumer commercial technologies to social care settings, and also some challenges. So I'm going to focus on on the Alexa work as more of the positive, so the benefits of using commercial technologies. Now, this project was like in the HCI realm, was kind of based on other research that is done. So there was a project that did conversational analysis on Alexa in social care settings, but it was looking at one sort of case study where it was like this guy, Ted, his Alexa and his carer, which is Anna, and looking at how sort of they were the interdependencies that happened in care, and how will Alexa fit into sort of that care management? But we wanted to kind of go further because this was only one case study where this was being done. And specifically, we were looking at the case of, well, we're getting rid of analog devices for these systems. So it's looking at, well, how is Alexa used in replacement of sort of CareLine? And CareLine is like the pendant alert system. I don't know, seeing some nods, people know what this is. So basically, if you fall, you push the button and it calls emergency services for you. And that is very much was tied to the analog system, and they've sort of modified it to be broadband now, but we were looking at, well, could there be alternatives? Because there is a lot of stigma that comes with sort of this CareLine device. I grew up in the States. I think Ashlyn can also attest to these commercials that happened where it was the older woman and it was like, I've fallen and I can't get up. It was a meme. It still is a meme, I think. And so people, especially when we're looking at social care is a broad range of ages and people. So if you're in your like 30s, you don't want to be associated with the I've fallen and I can't get up older woman. So with this research, it was going beyond sort of that one case study and looking at 10 different households. So these were then people of varying sort of disabilities, different social care needs, and thinking about, well, how would they use Alexa and how is Alexa as a sort of social care device? And this meant, because it was specifically being like, well, we're using a commercial technology for care, we broke down our analysis of the system and how it was used by sort of existing, like, what would you say, frameworks for analyze or understanding care needs. So thinking of activities of daily living, where it's like specifically CareLine is for ambulatory needs. So we really were focused on looking at ambulatory needs with Alexa, thinking about sort of steps to mental health. This is from NHS's website. And then also thinking beyond sort of just the activities of daily living, but the instrumental activities of daily living. So those are like things that are more like, obviously, Alexa can't help with toileting, but like it could potentially help with a lot of these instrumental activities. And guess what? When we analyze our data, we were able to find that Alexa could help in some emergency situations. It helped with 5 out of the 6 support sort of instrumental activities of daily living. And then I think there's plenty of research on how it helps with well-being, but we also found that too. Obviously, the most interesting of this, because of it being a CareLine replacement, where I'm going to just look at how Amazon Echo Show was helpful in emergency. So we saw sort of 2 ways that it was helpful. One with conducting physical checks, and the other like reacting in a physical emergency. So physical checks would be, if you think of Alexa drop-in, it's being able to drop in on your loved one and be like, okay, you're still alive. I can see you breathing in your chair. But then thinking about specifically reacting in an emergency, this was, I think, one of the most interesting things we found. So this photo is for illustrative purposes only. This is not our actual participant. I found this off the internet. Just so we know. Really, I mean, I wanted to convey that Brian, also not his name, was of younger age. He had hearing and mobility limitations and had visiting carers. He had frequent falls, and so his family was very much like, we want you to have CareLine. But again, as our illustrative photo shows, Brian was younger. He didn't want CareLine. He really and when we were like, we give you Alexa, like, see how this works. And during the case, so this was a 3-month study, and during that time, Brian actually did have a fall and then did use Alexa for an emergency. So this is to quote Brian, the carer said via Alexa, "We'll be with you within 10 minutes. Okay, I'll see you in 10 minutes. So I'm laid on the floor, I'm waiting 10 minutes instead of waiting there thinking, well, how long am I going to wait here for? So that's a lot better for me. I prefer it. I've got more control." So Brian was 39, male. So you can see younger demographic. And I think for him, really, the reason we give CareLine out to older adults, the reason we use it as a tool in emergency is to give sort of control and have people so they know and that they're going to get care, that they're not going to be just left on the ground. wondering when someone's going to come. But the issue is with how CareLine is, you're not directly contacting emergency services. You push a button, it contacts a third party. The third party contacts either your carer or it contacts, ambulatory care. While as with Alexa, it's a direct line to his carers. He says, call my carer, and it calls, and then he can know. That said, I think there's very much, we can all be pretty realistic because we know that this is Amazon Alexa. It can help in some instances of emergency. Like we showed Brian's situation, he actually was able to use it in an emergency. But that doesn't necessarily mean it's the most reliable in emergency. I think because of it being this large conglomerate company, there's limitations. Governments don't necessarily want to be like, yeah, let's give all of our medical data to Jeff Bezos. So I think in this country, you can't actually call directly like 119 from your Alexa. I think if you have your individual hospital number, it could call, but so it's not necessarily the most reliable in emergency. So if you call your care and they don't pick up, it's like, oops, I guess. Or if Alexa is a standalone device, if Alexa's in my bedroom and I fall in the bathroom and I can't shout for some reason and Alexa doesn't hear me, oops. So I think there is definitely limitations to using these devices in social care settings. And I think but it is something where it is but giving people these options, giving them the choice over what devices they pick, allowing them to not have to carry that stigma is something that's really beneficial to using commercial or consumer technologies. But there are also, I've already sort of touched on that there are challenges with using these devices, but I think it's really important to think about the baggage that comes with using consumer or commercial technologies. So I kind of touched on we already know that care devices come with their own baggage and stigma, but I think the same is true then that we don't think about with these commercial devices. And even if we apply sort of these commercial or consumer devices to care settings, there's still sort of this limitation of marketing, societal influences, trends, and the fact that companies want to make money. Or in this case, it was a research group. So it was research groups want to make a positive thing and have positive outcomes. So, and then they also kind of want to make money because they want to get more grants. Now, this was just sort of this mosh podge of different commercial devices that were used, environmental sensors, a watch, a wearable, sort of pulse monitor, thermometer, and there was a voice assistant included in this. And these were also, we gave it to people that were receiving social care, thinking, well, not just sort of on Alexa, Alexa is one thing, it has one sort of function, but if we have more of a passive monitoring system in these social care settings, what does that actually mean? And thinking about sort of the challenges and the baggage that comes with sort of these commercial devices, even if they're packaged for care, what still comes with this. So this was really thinking about the language that we use for this project. So it was thinking about, well, how do we actually frame our systems and frame how we not only design systems, but then develop and then market them and onboard them to people. So it was looking at the discourse. So the language that was used on the research company or research group's website to sort of promote their project, thinking about the guides that they developed to think about how they would onboard people. And then I did observe the technicians of the group onboarding our participants. So how they explained the system, how they explained how it would work, how they explained how they would read, they had access to an app. And so it would be well, how are you going to look at the app? How are you accessing your data? That sort of stuff. And then the question that we were looking at was then how does the discourse that we use to market and onboard sort of these home health monitoring systems match with actual care practices in the home? So actually, do they work with social care settings or social care practices? And this was thinking then about the dominant discourse that is sort of the societal narrative that we have that frames what we do, and how that sort of shapes the subordinate discourse, which is what people actually say. So does what I say match with what a company says? And what we ended up looking at, so analyzing different systems and different marketing and being like, okay, what is the dominant discourse that we see? And now you are all going to see these words everywhere. Independence, safety, and peace of mind. You will see it marketed for most devices for older adults. And you will, I'm only going to destroy independence. You can read the paper if you want to see, wow, fun noises. If you want to see the rest of these words be destroyed, you can read the paper. But yeah, so independence. So independence is a big one, I think, that comes up with older adults devices or devices marketed toward older adults, because yeah, I mean, it's what we want. It's thinking about sort of this positive negative continuum of independence versus dependence. And if you are independent, that is a good thing. If you are dependent, you cost a lot of money, you cost a lot of labor time. So it's all seen of as not great. So everyone wants to be independent. Everyone wants to age at home. Like, that's a big thing. I think what was it? Was it Thatcher that got rid of all of the institutions here? It was Reagan in the States. But basically they were like, let's get rid of all of the institutions, independence. And now we're using technology to create independence. And it was interesting to look at then how this system was marketed, because they said, well, let's empower older people to keep their independence at home. And I love this because, and I bolded to keep, because it is suggesting that your independence is being threatened. Like, if you don't have this technology, you will become dependent. You will not have independence. I mean, obviously, they weren't thinking like that deeply, but that is essentially what this is saying. And I think then it's really interesting when you look at, again, illustrated photo, look at how people actually thought about independence on their own. So this is looking at Ben and his wife / carer, Beth. And it was really interesting. So Ben was a former engineer, Beth was a former nurse. So they really had specific roles that they took in the household. So Ben would always take care of all the technology, Beth took care of all of the health stuff. And then we could even look at their language that they would use when they would talk about things independently. So Ben would use first person individual when he was talking about his technology use. So I use a smartwatch. Or when they were talking about sort of the care management, it's very much a first person collective. So we look at the data together. We go to the doctor together. So it was very much like sort of this first person situation for them when they talked about care. But then when we were like, here's a device, this will help you be more independent. It actually disrupted all of that. So they had this sort of first person, like us first, sort of way of managing their care. And then when we were like, here's a device that's supposed to help with your independence, they actually ended up having to rely on technical services a lot. And it disrupted then their approach to how they did care. So as we can see in this quote. So if there's anything I don't understand medically, I put it over to Beth, and she can read and she can interpret what we have to do. But I felt it fell short on a lot of information, because if I had that information, I wouldn't have needed the technician, but I did. So a lot of the times what happened is things that he could have normally solved on his own, or things that Beth could have normally figured out, they weren't able to do. They'd have to they'd call the technician and be like, what's going on? Why can't I read this data? Why can't I do this? And so it became then sort of this third party was entered into the care ecosystem. And it's interesting to think about that this was marketed as something that's going to make you more independent, when it actually made them more dependent. And so I think then what was really interesting overall in looking at this work and thinking about sort of consumer commercial technologies as social care devices is that sort of the discourse that we use to talk about these seeps into how we design them and how then they're used. So beyond sort of creating expectations, because when we do onboard, it does create expectations, that sort of then leads to influencing how the system is used. So if you're told the device does this, then you expect, and you're shown examples that, oh, the device will do this, then you expect that it will do that. And then if something goes wrong, this then also can create distrust between users. So we'd have issues where I think with this system, it would capture the cat. So like the cat would move and it would be like, you walked down the stairs 5 times. And the person would be like, I didn't. And in this case, our participants luckily had really strong relationships. And they're like, yeah, you didn't. And then they figured out that it was the cat. But there's always that issue of if you've been shown that this is how the system works and not told about this bug, then you might be like, wait a second, why are you walking up and down the stairs so many times? Like, what's wrong? Why do you keep going to the bathroom this many times? Why do you keep opening? And then that can create distrust, and then that can also help to break down care management and care ecosystems. So there's really like, this sort of adds to the limitations of just adapting or using commercial or consumer technologies. And then this also adds to, well, if we are going to use these, because they do have benefits, we showed that with Alexa. Alexa had a lot of benefits, but you have to then sort of think about how you onboard these devices to the social care people so that they know what they're getting into and know what the limitations, like really well, they know what the limitations of this device are. But then sort of the main takeaways between both of these and what we're thinking about is that what we really need and why commercial and consumer technologies are really helpful is that they help to create and allow for medical information to be more accessible to care recipients. Because especially if we think about the digital sort of switchover, having an Alexa can make it more, make sort of carers more accessible to certain people. It can help to make sort of medical information more accessible to people. I think, Ashley, we can think with like Rachel's work. I don't know if any of you know Rachel Keys. She does stuff with smartwatches and monitoring hearts. I think like this commercial technology allows people to have more awareness of their health, or can allow some people to have more awareness. Again, not everyone. But it is that we need to be clear when we're introducing these devices as sort of tools for helping with medical situations or helping with any sort of social care situations, like what the limitations are of them and what the benefits are, so that people aren't maybe trusting things beyond what they should be. And this is me being, as I introduced at the beginning, I'm really into interdependence. I think that there needs to be going beyond this idea of independence or dependence. I think that it's very limiting language, and I think that it's very much a continuum where dependence isn't always a bad thing. So that's my big soapbox thing. But then the final thing is to think about how data is managed responsibly. So I think we even saw, if we think about Amazon, that's a whole other can of worms about data responsibility. Who's owning that data? Where's it going? What commercial purposes will be used for? But I think then, even looking at the research project, like them managing that data, we had they had to keep going to the technical staff who didn't know anything about sort of healthcare for like when they had questions or problems. And that's also an issue when you're like, hello, engineer, why is it saying that my heart isn't working? So really thinking about how are these systems designed and working with both engineers and clinicians to be able to sort of manage that care system. Now, the final takeaway is that this work was done with Bristol City Council because of it having some sort of that like policy interdependency. But I think that there's something that's really important is to think about how we as academics can have greater impact on policy, and the research that we do can have impact on greater policies. So actually, you can go to the policy briefs, and this is the website. Me and Aisling, wrote a policy brief that has gone out to various government agencies about this research. And I think it's really important, especially because of Labor's sort of position on the NHS and fit for the future, I think is their slogan, that I think we as digital health researchers do try and get out what we are studying to policymakers to help shape the future. And that is it. About 30 minutes. It is really warm. I think we we could end this early.
Does anyone have any questions in the room? Online, I guess. Does anyone left anything in the Q&A? Well, I guess we can start with the room for now. Yeah.
I know it's at your last point, but your policy briefing, I am curious. How does this make impact? What does it look like? Do they ask you?
So yeah, this is great. So essentially, Bristol has Policy Bristol. You go to them, you go, I have this great research, and then they give you a template, and they go, fill out this template. It's very short, it's very easy. It's like write a 180-word sort of summary, and then write some nice, cute bullet points of like what your main takeaways are. And they help you write it, they help you edit it, and then they help you disseminate it. So basically, I think for engineering, our policy person is named Amy, and Amy is, you're also Amy, another Amy McNeil. She was excellent to work with, and she just spammed so many policy people. Like she like CC'd me in on the emails, and it was just like, and she did warn me before. She's like, I'm sorry, you're gonna get a bunch of emails. And it was just like spam, 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 spam. And then we did actually, I ended up, I think, forwarding you this, Aisling. But like we did have one of the people that got spammed was like, this is really interesting, and forwarded it on to another policy person. So that's why I'm like, do this. It's fairly easy. And it looks cool. Yeah.
I hope you get another email coming back being like, oh, we made this change.
I know, that would be great. I don't think we will, but it'd be great. Yeah.
Did you have any issues with ethics? Because obviously with like voice assistants, right? Like it's not a closed loop.
Yeah.
So any of the data that's being given to that is then presumably going back to the Amazon, etc. And so I'm from voluntary sector. I got one of my guys set up with an Amazon a while back, and he loved it because he was non-literate.
Yeah.
Right, but he was able to use it to do so much stuff that he wasn't able to do before.
Yeah.
But I didn't have to go through ethics then because it was working in voluntary sector. But how was that for you?
I'm gonna pass this over to Aisling because I was not there for the ethics. I only had to.
Which means I went through okay. I think
Yeah.
there's some pushbacks with reviews and pushbacks of anything. We're currently working with sociologists now who are kicking back at it. But this wasn't put out as an intervention. This was put out and see what you do with it. They did use it in emergencies, but that didn't mean that it took off Caroline and drew it out. So they weren't relying on it. So it's
Yeah.
thing out there. So ethics went through okay, but this is it's not a weird technology. It's very common technology. And so the people who signed up for it were very aware of, I'm gonna get my lens.
Yeah, because it was, they got to keep the Alexa, so that was kind of the motivation for joining. And then it was like, we were very much like, this is not, you must use Caroline, you will still have Caroline. So like, even our example, Brian, like he still had the Caroline device, he just didn't want to use it. So yeah, I think that's how we got around it.
So, no one gave up the Alexa, but for the research group one, a bunch of them.
Oh, yeah. Yeah, they were allowed to keep that one. They didn't want it.
They did not want
I don't think anyone kept
People
it.
made choices with that, but we weren't that interested in security and privacy. I still am not that interested in security and privacy because a lot of people just give away their data, so why wouldn't it be also?
Yeah.
I'm curious, with Beth and Ben,
Yeah.
did you have any other participants that weren't in that didn't have a care relationship within a marriage? And did you still see that same sort of shift away from independence in participants that didn't have a carer at home, particularly one with a medical background?
Okay, so I'm gonna piece this apart because so we had households where it was just an individual living alone, so they didn't have necessarily a carer. I think in any of the care situations where it was spouseless, ironically, I think all of the women did have some sort of like medical, because I think the other one I can think of, had some sort of like sociology background. Yes. So I'm sorry. What was the question again? I was still trying to piece out like who my participants are.
Starting with independence and then moving towards dependence with the introduction of technology, when there's already a dependent relationship there
Yeah.
between then and there.
So did they become more dependent? I think for a lot of the people that were living alone, because they didn't have, they kind of just, I think they just abandoned the technology because it didn't work. Like they were like, oh, I'm not going to be dependent on this device. Like I have other systems that work, other things that work for me. And yeah, that's where I think we did see a lot of abandonment, were the people who lived alone, which was kind of ironic because that was one of the big marketing things. They were like, for the older adult that lives alone, like you can spy on them. Again, that wasn't their exact marketing.
But the inclusion criteria, they're all in receipt of social care.
Yeah.
All of them are technically dependent.
Yeah, I think like, so this is the side work that I've done. But like for my personal research, so I work with people with dementia or couples that have, where one of the people has dementia. With technology, I think technology, if anything, it is either not used by the person who is more dependent, or or in some ways it helps the person who is the caregiver become more independent. And this is why I don't, like, I think of it as sort of they're still interdependent because they haven't been divorced. And they're still getting some benefit. They might just not get the same benefits as before. So I think it's very much just sort of like there's independence, but it's still sort of, yeah. I don't know if that, yeah, but I think it's something that needs to be a little bit more, like it's definitely an area I'm interested in exploring more, in thinking of like that continuum of interdependence, where it is thinking about when you introduce technologies and there is sort of like dependency or in like abandonment, kind of what happens. And I think especially with AI, we're seeing a lot more people become socially dependent on AI. I'm reviewing for Kai this year, and I luckily did not get assigned any of these papers, but I saw lots of papers about relationships with AI. So that seems to be the trend this year. And so it's definitely, I think, something that is interesting, where are people going to become more dependent on this technology, and how will that affect actual relationships or in-person relationships? Yeah.
I made my husband change his ChatGPT voice.
Was it a girl? Is it a boy now?
So yeah, I was thinking like with people who are dependent or like using this technology, was there a difference in like the acceptance of the use of it? People that are used to technology and like quite technology literate, and the people that maybe don't use technology at all? Because that's like one of the things with the digital switchover, right? Is that people have got a landline, but they don't have an internet connection. So
Yeah.
there's always there's already that discrepancy, but sometimes people can be surprising with like being really accepting and using this Alexa. But yeah, so I was wondering if you noticed any like differences there.
Yeah. So there was an interesting case where we had one person who was in both the Alexa study and the like research group thing, and she loved the Alexa, but she hated the research group. And it was because I think partly due to the onboarding experience. So I think with the Alexa, like this research was done during COVID, so there was a lot of social distancing, and like we were like, we can't help you, like sorry, we're trying to see what happens. Like, and this is also partially why we saw abandonment. But like with this, she had a friend come in, like that trusted someone in her bubble come in and set up the Alexa for her. So I think that gave her a little bit more confidence, and she was like, oh, this is kind of fun, it's cute. But then it was funny because then once she got the other system, she unplugged the Alexa and then couldn't figure out how to get the Alexa to work again. So there's definitely an issue where like there is a drop off because people don't understand technology. But I think there's a researcher admire called Amanda Lazar, and she once gave a talk, or she was talking about her own experience, where it's like as she gets older, even I get older, there's a lot of things that I'm just like, I'm not interested in learning this. I don't have the motivation. I don't care about Snapchat. Like, I never learned Snapchat. I was around when Snapchat came out, and I was like, don't care. The same with TikTok. I have no interest in, I'm like, I see how addicted people are. I'm like, I'm not getting on this. So I think there is sort of, there's a lot of research, I think, on people's resistance to adopting technologies and how that kind of, does exclude them from sort of society. And I think that's a big issue that older adults have. And I feel like I just rambled, but it is. So I think there is a lot of like, we definitely saw it where it was like, you saw that some people who were more technologically inclined, more interested, more motivated to learn this technology did have better experiences. But sometimes that onboarding experience helped to create that motivation. Yeah.
That's great, thank you.
Yeah. Yeah, I think it's you.
I think it's more a point for discussion rather than a question, but it's about using consumer technologies that are available to only some people, because not everyone has the latest smartwatch.
Yeah.
And then how this can affect, if implemented in healthcare or accepted by healthcare. Like, okay, we can follow this treatment. What type of devices do you use? Oh, but you don't use the latest smartwatch. Okay, then you cannot be covered by this care path or whatever.
Yeah.
And how do you see all of this going forward in the future? Is it that it's only a test bed to see what is possible, and then NHS or whoever then needs to create their own, that it's available to every single person, or how do you think about that?
Well, I mean, I think this is where this work spawned from. So like working with Bristol City Council, their social care, they already do provide some technologies. So like you and my predecessor, right? No, Pierre. Well, Pierre, he was before me. Like I'm thinking he did a work on stair lift. And stair lifts it's basically do you know what a stair lift is? It's essentially a chair. It's a chair that you put and attach to your stairs, and it automatically like helps you go upstairs.
Yeah.
And so that's a technology that the councils offer as a sort of like, if you have mobility issues, we can offer you this technology. Yeah. And so this project that we did, it was like, well, we want to expand the sort of list of what technologies we can offer. Yeah. So this is where we're kind of like, we know that there's lots of stigma against things like stair lifts and things like mobility scooters and all of this actual like medical tech. So what if this is Ashling's, all of her work on diabetes, where it's like people hacking commercial technologies and all of this stuff. We know that people can use these commercial devices in these situations. So it was like, well, let's take this opportunity, because we know there's this switchover, thinking about how we would apply these and use these. And they could then offer it as like, oh, you want Alexa? Okay, we'll buy you an Alexa. Here you go. So that was kind of how this pathway would work. So it wouldn't be that you have to personally buy the device, but like it could be something that could be provided as a care tool. So that was how it would work for us. I think there still is disparities with that, because I think even though there's been this sort of digital switchover, there's still issues of like, how reliable is that? How good is the network? What is rural Scotland, do they really have the same sort of 5G network that we have in other locations? I think even working in 1CS, I have worse internet than I have at home. So I think there's a lot of differences that happen with that, where there's going to be disparities with digital devices because of just like how, let me bring up my word, interdependencies, the interdependencies with sort of the network systems.
Yeah, and also I can envision certain devices being accepted by NHS or whoever, and then companies competing against each other just
Yeah.
to see which is the company that is the provider for the
Yeah.
NHS, and then consumer products evolve quite very quickly,
Yeah.
while the NHS needs some standards, and all of these
Yeah.
interdependencies on how technology. Yeah.
Sorry, you used my word.
Yeah. How technology evolves, but NHS doesn't want the latest
Yeah.
things that have been proved.
Yeah.
Yeah, I think it's very interesting, and it's something that I am interested.
Oh yeah. I think it's a dilemma, because I think one of the major benefits of commercial technologies is because these companies are invested in it, they will update it and make sure that it's constantly running to the best of its abilities. Well, if you have something like the NHS app or something where it's like it's only go so far because they need to make sure that it's rigorously tested for privacy and all of that, and it's not going to keep up with the way everything else is moving. And I think this is an issue we have with AI in healthcare, is that it's not keeping up. There's like we know we need this. We don't understand this. We don't understand how to manage for the privacy. We don't understand how to do this. Let's just not do it. So I think there is a lot of like, let's just not do it. Yeah.
Sorry.
Yeah.
Is there other people online?
No, I'm asking my own question.
Oh, go for it.
I was just wondering, so you talked about the importance of kind of like onboarding and giving kind of really crucial information about like the limited capabilities of the technology and interpreting that. And that's something that I've noticed is very challenging when you have people of I say lower tech literacy.
Yeah.
I wondered if you had any thoughts on or like success stories or anything like that on how you found that.
Success stories. Of lower. Ashley is nodding like she has an example. What example are we?
Alexa. So Unix are safer. So we gave out Alexas
Yeah.
to older adults during COVID, and a lot of them had nothing, no mobile phone, nothing. I mean, this was a voice interface. They used it, and the families called it a lifesaver. It sounds like I work for Amazon. They've given me nothing, but I like this product. This product is excellent for people with low tech literacy, because the act of having a conversation, although disjointed and you get mad at it, you can still look up information in a way that someone who doesn't have a mobile phone or internet cannot. Sorry, a laptop. So.
I guess in other work that I've done, I've seen that like, because of it applying to commercial technologies, you tend to then be able to ask more people. So like if, like, for instance, you have a Dell, I have a Dell, you probably have the same issues with your Dell that I have. So there's something where it's like, if I have an issue, you might understand how to do it. So I think there is a bit of like that social element of being able to help with some of that onboarding experience. And like, again, with the one example I have of the woman who had the Alexa versus the other passive monitoring system, like she was able to go and ask a friend to help with that, while as like this other system was externally controlled and managed. So it was like, well, I can't ask my friend to help with that. They've never seen the system before. So I think there's a little bit of that. But then, I think, as Ashley was saying, it depends. Like it is the design of the technology. So I think this is something where we can see that AI is helping with this, because it is allowing for more natural language processing and all of that sort of things that can allow for more natural interactions, where we can interact with technology as we would interact with things that we're used to, like normal affordance interactions. Yeah.
So I just wondered if you'd seen like any kind of trend towards commercial technologies kind of focusing more explicitly on these kind of social care challenges and incorporating features that are not just kind of, I feel like, piggybacking off of features that they've added for commercial benefits. And then, like the fact that it has an internet browser so you can go shopping also then means that you can access the internet to do some of these things that the people want to do. But I imagine it wasn't intended for that purpose initially. Do you feel like companies are moving towards that more explicitly, like kind of recognizing that as a need?
So some of them are, yes. So Alexa in the States, but I don't think it was long lasted. They had Alexa Care or something like that. And actually I used their marketing. Their marketing also, they use independence, safety, and peace of mind. And it was very much where they were like, oh, we recognize that people use this for care, like to help with like distance care, especially the drop-in stuff. And so they were trying to market it and make more money. And they're like, we'll have this special feature. Yay, you only pay like an extra $100 a month for this service. So I think some commercial technologies recognize that, but it's definitely, I think they kind of avoid it because they're like, this is a whole other can of worms that we don't want to open. Because it is like, if you go into the care space, there's a lot of different regulations that you then have to cover. Well, is it like, and I think this is, I don't know if any of you, there was a guy that came and talked about sort of medical device regulation. And he was like, just avoid it. Just call it a well-being device. If it's a well-being device, you don't have to do any of this. And it's a lot easier. And so like, that's a lot of commercial technologies that are like maybe helpful for health. They'll just go, it's for well-being. It'll help make you feel maybe better, but they won't make any claims. So it's all about skirting regulation. Yeah. So that's, I think, the trend I've seen. So there's a lot of like, yeah. Well, especially AI for care. It's all well-being. That's just maybe, yeah. It'll help with care. It'll make you independent, and safety, peace of mind. Like none of those are actual medical things. Like, but yeah. It is almost time.
Any more questions in the room or online?
5 minutes.
I think we'll close it there then.
Great.
I know it's really hot.
Yes, well, thanks.
Yeah, thank you.